Good morning, everyone. This is Tiara speaking. We are just going to give it a couple of minutes to allow people to join, and then we will get started. Morning, everyone. Again, this is Tiara speaking. We are just going to give it another minute before we get started to allow everyone to join. All right, this is Tiara speaking. We are going to go ahead and get started. Good morning, everyone. My name again is Tiara Yakini. I am with the Disability Rights and Compliance Division at the Michigan Department of Civil Rights. I will be your moderator for this session. For a brief description of myself, I am a dark-skinned African American female with curls in my hair, and I am wearing a coral top. For full accessibility, it is critical that speakers first identify themselves by name before proceeding to speak and mute their microphones after they are done speaking. We have ASL interpreters on screen, and live card captioning is available by turning on subtitles using the CC icon on the lower part of the screen. The host will make sure that a spotlight is on all presenters and interpreters. To view both the presenter and the interpreter, along with any presentation materials, please make sure that the gallery view is selected on your personal device. We will have a question and answer portion during today's session, and attendees can use the Q&A function on the lower part of the screen to type questions for our panelists at any time. With that said, it is my honor to welcome you to today's program, Closing the Gap, Addressing Health Disparities for the LGBTQ plus community. This important event brings together a diverse group of speakers to shed light on the healthcare access gaps faced by individuals at the intersection of two historically underserved communities, people with disabilities and members of the LGBTQIA2S plus community. Together, we will explore the challenges and opportunities to create a more equitable healthcare system for all. We have a dynamic panel of presenters who are going to speak to us about the need for accessible mental health care. Please join me in welcoming Dr. Shanna Katari, an associate professor and researcher from the University of Michigan, Brody J. Lobb, a clinical social worker and therapist in Michigan, and Dr. Adrienne Rowland, a certified sex therapist supervisor specializing in sexual health with a particular focus on LGBTQ plus and gender affirming care. We're going to start this program by exploring Dr. Shanna Katari's research study highlighting mental health care access disparities in the LGBTQIA2S plus community. Dr. Katari is an associate professor of social work and women's and gender studies at the University of Michigan. As a community engaged, multi-methodological researcher, their researcher focuses on queer and trans affirming care, sexuality and sexual health, disability, and ableism. Dr. Katari, you now have the platform.
Hello, this is Shanna Katz-Katari. You see on the screen a white, red, curly-haired, non-binary femme with rainbow glasses and cloud rainbow earrings in a teal blazer over a blue and white kind of honeycomb patterned dress. And my background is full of things that indicate queerness and transness and cripness and cats. So I'll start with the next slide, please. I do want to acknowledge that we are on the ancestral, traditional, and contemporary lands of the Anishinaabe, which is the Three Fire Confederacy of the Ojibwa, Ottawa, and Potawatomi nations, as well as the Wyandot Nation. However, while we must advocate for Indigenous struggles against ongoing colonization and strive for a decolonized future, words by themselves are not enough, and decolonization is more than conceptual. So I encourage you to please check out the Land Back movement, the Real Rent movement, and other movements led by Indigenous people locally. Also, here on the land that we call Turtle Island or the United States, our spaces are built on the backs of and through the labor of enslaved Black people. So we should honor the legacy of the African diaspora, Black life, knowledge, and skills stolen through violence and white supremacy. And as a side note, while it is Pride Month, next week is also Juneteenth. And if you're not familiar with that holiday, I encourage you to look it up and learn a little about it. Next slide, please. Also, an access reminder, this is a body-mind friendly space, so please take care of yourself while you're sitting, standing, or engaging the next 2 hours. Please feel free to move your body, sit, stand, lie down, stim, stretch, close your eyes, etc., whatever it takes to be present in this space. Also, the three of us are being presented as experts, and I don't really believe in anything other than being an expert in your own identity and own experience. So a reminder that we're all learners and we're all teachers. And just while I have 175 people's attention, I'll remind you that the pandemic is ongoing. People are still dying by the hundreds and thousands every
Oh
month.
my goodness.
And I would encourage you to consider wearing a mask to be in solidarity with and to protect chronically ill and disabled people. Next slide, please. LGBTQIA2S plus people, which is lesbian, gay, bisexual, transgender, queer, intersex, asexual, and two-spirit, disabled people are having to decide in making the choices between getting appropriate care for themselves and getting queer and trans affirming care. For example, if you go to the doctor's office, you might have to decide, do you correct your provider in using your correct name and pronoun when you go so that you feel affirmed in your gender and your body and space? But knowing that it might change how they interact with you or result in you getting lesser care or not having care at all. And that's a really difficult decision to have to make. Other issues we run into are, for example, that mental health inpatient facilities, as well as other facilities like for substance use treatment, are often divided by gender. And so when you are either needing to go there yourself or referring a client or a patient there, you might need to assess, are they trans affirming? Will trans women be placed with women or will they be placed with men? Will trans men be placed with men or will they be placed with women? What if you have a non-binary client or patient? If they say that they will place a trans woman in her own room or separate unit, does that mean she doesn't get access to the rest of the support groups and other things that are designed for other women? And similar issues arise. Next slide, please. Providers who are specific to being LGBTQ inclusive might not be accessible for people with disabilities. For example, there was a post that made the rounds in a lot of disability groups online last year, where a fairly well-known queer affirming therapist posted that, and this is a quotation, "One person cannot be inclusive of everyone," end quote. And he was fine having an office that was up a flight of stairs. So again, people are having to decide which identity is most salient or most important in a moment. And sometimes they don't even get to make a decision. If you are someone that cannot climb stairs, then you don't necessarily get access to that person, even if you wanted to make the choice for your queer identity to take the forefront. Similarly, specialists, providers in specific areas or certain types of illnesses or types of disability, for example, a special neurologist or someone who specializes in EDS may not be LGBTQIA2S plus affirming or even aware around those identities. And I'll give a personal example. Last month, I had an amazing physical therapist here at Michigan Medicine. She was great for my disability related care, really affirming, believed in me. And she and all of the other physical therapists and the fellow patients in the pool consistently misgendered me despite being corrected. So every time I went to physical therapy, I had to decide how to react, how to respond instead of focusing on my own care. Next slide. And when we compare trans people to their cisgender counterparts, and cisgender just means non-transgender, disabled transgender individuals were over 4 times more likely to be unable to see their doctor when they needed to, 3 times more likely to be unable to get prescription medication when needed, almost 3 times more likely to be unable to see a specialist as needed, and more than twice as likely to be unable to get dental services. Next slide. When attempting to access specifically mental health services, mental health centers, 6.2% of non-disabled trans people experience discrimination compared to 17.3% of trans people with one or more types of disabilities. We also saw differences within types of disabilities and experiences of discrimination, with people with physical disabilities actually experiencing the least amount of discrimination, although still at 13.8%, which is a very high rate when accessing mental health, all the way up to people with multiple disabilities experiencing 23.3% of experienced discrimination. Those with learning disabilities experienced 15.8% experienced discrimination, and 15.5% of those with socio-emotional or psychiatric disabilities experienced discrimination. So the rates of discrimination ranged approximately from twice to almost 4 times that of non-disabled people. Next slide, please. In 2018, I partnered with Transcend the Binary, which is a nonprofit organization based out of Detroit that serves the state of Michigan, to run the Michigan Trans Health Survey. We had over 660 respondents, and 43.25% of the sample identified as people with disabilities or disabled. And at the time, that was compared to the national rate of 27% of the population. So an incredibly higher number within the trans community identify as disabled. Only 51% reported 51% reported mental health as only fair or poor. Over half, 50%, had current depression, with an additional 23% having had depression in the past. And 54% had current anxiety, with an additional 20% having anxiety in the past. Half of the sample, 50%, had suicidal ideation, which means thoughts of suicide in the past year, and another 25% had had them in the past, so 3/4 of the sample. 8% had attempted suicide in the past year, and an additional 25% had attempted suicide in the past. So that is 33% had attempted suicide at some point in their life, which compared to a national average of all people is 1.4%. So incredibly high rates of suicide attempts in the trans community here in Michigan. Next slide, please. Additionally, 61% of our sample chose to delay needed healthcare for a variety of reasons. 17% didn't have a trans-inclusive provider near them. Thinking about, for example, the upper half of the Lower Peninsula and the entire Upper Peninsula. At the time, there were no therapists who specifically said they would see trans clients. And so some people were driving 3 to 6 hours in order to get basic care. 46% delayed care due to fear of gender-based discrimination, so trans-related discrimination. 29% delayed due to their insurance not covering trans health needs. 11% said their insurance was not covered by trans inclusive providers, and 38% could not afford their needed health care. Next slide, please. In 2020 and 2021, sorry, 2021 and 2022, we recruited trans students at the University of Michigan to talk about their experiences. We had 120 respondents. 51% of the total sample identified as disabled, again, compared to the national average of 27% of the US population. And when we compare the mental health ratings of our students compared to the mental health ratings of US college students as a whole, fewer rated themselves as excellent, very good, and many more of them rated themselves as fair and poor. So 1.7% said they were excellent compared to 6% of the US college students. 8.6 said they were very good compared to 16% of US college students. 21.6 said they were very good compared to 32% of US college students, while 48.3% said their mental health was fair compared to 33% of US college students, and 19.8% said their mental health was poor compared to 13% of US college students. Next slide, please. Additionally, when trying to use various services on campus, 15.6% experienced discrimination at our psychological and counseling services. 13.9% experienced discrimination regarding their gender at university health services. 13.3% experienced discrimination regarding their gender at services for students with disabilities, which is what sets up accommodations for students on campus. And 15.9% experienced discrimination regarding their gender at Wolverine Wellness, which kind of encompasses everything else around health on campus. And I should note that with all of these numbers for both surveys around discrimination, this is only looking at people who tried to access services, not the entire sample. Next slide, please. But we also wanted to know, what are people doing to be healthy, right? We tend to think about mental health, especially in the queer and trans community, as a deficit. We see really high numbers of depression and anxiety, as you already saw. But students on campus are doing lots of things to take care of themselves. So about 2/3 of our sample, 66%, do therapy. Others responded with traditional methods like taking their medications and vitamins, working on sleep, sleeping more, working out, healthcare visits, eating, quote, healthy/good, end quote, foods, stretching, and remembering to eat regularly. A lot of them also responded with self-reflexive methods like journaling, going outside, listening to music, meditation and yoga, cooking their own food, making art, crying, same, being mindful of our own sensory needs, and also connective methods like playing video games, connecting with other queer and trans people, going to a sexual assault support group, hanging out with friends, connecting with pets, and sex. Next slide, please. So, as I finish up, these numbers tell us a lot about some of the issues in the community. So, what can you do? You can create accessible spaces both virtually and in person. You can deconstruct what health means to you. Is it really about being non-disabled or about having to make direct eye contact, moving your body, never being depressed, or simply taking care of your mental health? Asking more open-ended questions like, how do you feel about blank, instead of making assumptions? What are you doing to take care of your body and mind rather than how often do you work out? What else would you like to bring up to me? Curiosity allows a lot more space for people to engage. You can say things like, you said you're struggling with blank. Can you tell me more about that? Giving space for them to share all of the different facets, because issues around accessibility and disability may come up, as well as issues around gender and sexual orientation and attraction. Listen to your patients and your clients. It's already so hard for them to bring things up to you. And validate their realities, whether it's pronouns that you might not have heard of before, or the fact that they're just exhausted all the time, the fact that they're depressed. We're currently living in a world in which trans people and queer people are constantly under attack, validating their pain as real, etc. Next slide. Again, believe your patients and clients. People don't have to look like they're in pain to be in pain, and that is both physical and mental pain. People may not look like they're members of the LGBTQIA2S plus community. I often get read as straight or as cisgender. Neither is true. People often don't, quote, look neurodivergent, whatever that means. Always leave space for patients and clients to bring things up to you and be intentional with your reactions. I always tell people to learn to fix their face. Keep educating yourself on language, on activities, on the needs of the communities with whom you work, and have a good list of resources and referrals. Use them whenever needed. There's no shame in referring out if you are not able to support someone in the way that they need and deserve. Next slide. Create more accessible practice spaces. So be really intentional in creating your office spaces, exam rooms, etc. Provide ASL, American Sign Language interpreters, and or captioning options and how to access them. And a big thank you to our interpreters and CART captioner today. Share where accessible spaces and parking can be found. Use readable fonts and provide screen reader accessible documents. Offer low and no scent spaces. Offer to mask, physically mask, and use air filters, or offer telehealth options. Have different types of chairs, chairs with arms, chairs with no arms, benches, higher up chairs, lower down chairs, sofas, etc., to allow people to choose chairs that best fit their bodies. Offer sensory friendly spaces with lower lighting, fidget toys, etc. Offer weekend and evening appointments as possible. Wear pronoun pins or share your pronouns first. Gender inclusive, accessible bathrooms and signage should be available everywhere. Next slide. And those are the physical things we can do. We also really need to think about restructuring how we view identity. Disability is often seen as something to be fixed, and queer and trans identity is often seen as separate from needs around health and mental health care. But if we use self-determination to validate people who they are and how they identify, person and environment approaches, which locate someone within the larger context of their family, their community, their political things that are happening, we can better understand everything that's going on and how to support them, and using empowerment approaches to support people in really feeling, I'm defining a word with a word, but feeling empowered to approach their own mental health in the way that works for them and their body mind. Please don't divide by sex or gender if at all possible. You only need to collect sex for insurance purposes usually, and you can put that on your form that says sex and then in parentheses, needed for insurance, and then have a blank based on gender. Ensure that gender-based support groups are inclusive of trans people and also offer non-gendered groups and spaces as well for people that don't want to be in a gendered space or whose gender may not fit within the binaries of the groups you create. Recognize that disability is both a social identity and marginalized community, in addition to being part of natural human diversity. And recognize that people shouldn't have to choose which identity is most salient at any given time. Next slide, please. And while I have a captive audience, we have just launched the 2025 Michigan Trans Health Survey, and we'd love for you to help us get better data. Especially right now, the census, the Behavioral Risk Factor Surveillance System, or BRFIS, and the Youth Risk Behavioral Survey, YRBS, which are all of the data that is collected at the state level and then nationally, no longer collect any data on LGBTQIA2S plus people. Therefore, we have to collect our own data to know what's happening for, to, and with us. So if you or anyone you serve is 18 plus in Michigan and identifies as trans, non-binary, gender diverse, of trans experience, two-spirit, or any other non-cisgender identity, please take our survey. You can win one of 50 $50 gift cards. You just need to visit mitranshealthsurvey.com, and we'd love for you to share that widely. And with that, that is the end of my presentation. Thank you all so much, and I look forward to questions.
This is Tiara speaking. Dr. Katari, thank you so much for highlighting the data. It really gives us a clear picture of the gap that currently exists and the areas in which we can make impactful improvements. We have received some questions in the chat regarding availability of the slides and video replay. The slides will be shared following the presentation, and the recording for this session will be available on the MDCR YouTube page. As we continue this discussion, I am happy to now welcome Brody J. Lobb. Brody is a white, queer, transgender man working and living in Ypsilanti, Michigan. He earned his BSW from Adrian College in 2019 and his MSW from the University of Michigan School of Social Work in 2020. His primary focus as a social worker is providing clinical mental health services using anti-oppressive and gender-affirming lenses to transgender and non-binary individuals and their families across the state of Michigan. Brody Lobb, the floor is now yours.
This is Brody speaking. Thank you so much for that introduction, Tiara. As mentioned in my introduction, you are seeing a white masculine presenting person with short brown hair, brown facial hair, a short sleeved collared green shirt. And in my background, you see what all of my clients see. You see my office space in my apartment. There's a rainbow piece of artwork that a friend of mine did many years ago. Um, and a lot of the books that I use to reference um, to support my clients behind me as well. And I am really excited to be here, and I'm really grateful that all of you are here with us today as well. Next slide, please. Um, so a little bit about my practice and myself. Again, in my introduction, I graduated with my master's degree in 2020. I did my practicum placement in my master's program at a private practice in Southfield, Michigan. So almost all of the work that I have done post graduating with my bachelor's degree has been in outpatient private practice, almost exclusively working with transgender and non-binary clients. That was very intentional. And that is what I knew I wanted to go into clinical social work doing. Um, so I have been seeing clients since late 2019, and I believe I've definitely getting close to 150 folks over that time frame. And I believe there's only two or three that have not been transgender or non-binary. Um, a lot of folks may label me as a gender specialist. I really push back against that label for a lot of different reasons, but one being that especially even if folks are coming to get specifically like affirming healthcare to help them access gender affirming medical care, whether that means that they're pursuing like if gender affirming hormones or gender affirming surgeries, um, especially after we finish that work, if we continue our mental health journeys together long term, gender is not necessarily the only thing that we're talking about. Often it's not the only thing that we're talking about. And we're not always talking about things that are directly related to their gender identity. We're talking about how to set healthy boundaries. We're talking about potentially like childhood traumas and how those are impacting how they're navigating life as adults or as older adolescents. But especially over the last 3 or so years of my clinical practice, I started seeing other patterns of experiences, especially disabling experiences that a lot of my clients had in common. A lot of folks come into my practice already having diagnoses of things like ADHD or autism, or while we're in sessions together, they start questioning and saying, "I think I might be neurodivergent. This might be part of my experience." And so we have a lot of open conversations about that and navigating if a formal diagnosis is something that they want to pursue or not, what kinds of things help them to access different spaces and to advocate for themselves for accommodations if they need so. Um, I also have folks who experience chronic pain and chronic fatigue for a variety of reasons. Um, a lot of folks navigating chronic or complex post-traumatic stress disorder, and as you could guess, a lot of folks navigating the challenges of chronic gender dysphoria, whether that is more mild experiences or around specific experiences or parts of their bodies, all the way up to like more moderate or severe and extreme cases of that as well. Um, Building off of Dr. Katari's points, they shared a lot of really important information and data about what especially trans and non-binary Michiganders experience, and in the broader LGBT community as well. One thing that they mentioned right at the end is one thing that we all can do is redefine what health means to us and how we may apply the standards that we have around health to the folks that we work with. Especially for my clients who experience any of these disabling experiences, but even more broadly for those who don't, our conversations often reframe health as wellness. And that sometimes helps to open and broaden the conversation and the lens around like what does wellness mean to this like very specific person in these different areas of their life. A lot of times that obviously focuses on emotional and mental wellness, but that can also include physical wellness. And it's not only about what is going on in my body and brain, but also that includes things like occupational wellness. Am I at a job that I feel respected and valued at? Am I able to be out to the folks that I work with? And do they respect and support me in navigating my transition, for example? That includes things like social wellness and financial wellness and environmental wellness, right? I believe spiritual wellness is also something that we talk about off and on, depending on the person. So in doing that, especially for my folks who have multiple different kinds of disabilities, that also helps to center our conversations on recognizing what they are able to do and where there might be limitations in what they are able to do, and working with that, whether that is physical disabilities or mental or emotional disabilities, if that is neurodivergence, whatever that might be for that person. My approach is never to say, this is the standard, how can we meet it? It's more about asking my clients from a really client-centered perspective, what does wellness look like to you here? What would that mean for you? What are you already able to do? And where can we develop different strategies or find different adaptive tools to make different experiences more accessible for you? Um, the majority of my part of this panel presentation is really putting a face to, again, a lot of the numbers that Dr. Katari shared before, and a lot of the experiences that they shared before. So you may hear some familiar things, but I wanted to share a client experience of mine that really encapsulates a lot of the things that they've already shared. So Stephen, if we can move to the next slide, please. I want to introduce you to a client named Julie. This is not my client's real name. It's just for the sake of our work together today. But Julie is a 42, currently 42-year-old white transgender woman. And I have been working with her, about 4.5 years now, actually. Um, and Julie's story starts far earlier than when she and I started working together. She has over a decade of childhood abuse and trauma, a history of physical abuse and emotional abuse and sexual abuse and religious trauma. She grew up in a family that was really entrenched in a really close-knit Christian community. Um, and as you may imagine, as a transgender person, growing up and knowing that she was transgender from a very young age, she grew up in a community that was really demonizing that and really saying, if you are this kind of person, if you are um, experiencing any kind of gender variance, let alone expressing that gender variance, there are really serious risks of rejection from the community or withholding of love and acceptance, or much more broadly and globally, you are going to hell, right? Those are a lot of the messages that she received as a very young child. And so she had to suppress that for a really long time. And she did her best. She did her level best to suppress that as much as she could so that she could be accepted by her broader community, by her family. She went on to get degrees in accounting and and still is really driven by social justice. And so she was doing accounting work for a lot of social justice oriented organizations in her community. But as she's struggling with all of this childhood trauma that has been unresolved and unhealed. She has a long period of time where she struggles with substance abuse. Alcohol being the primary substance that she really struggles with and often leads to contact with the legal system, contact with police. Um, and this begins to establish a criminal record for her, unfortunately, for a variety of reasons and a variety of intersecting, discriminating experiences. She does end up coming out as transgender in her mid-20s. I believe as an adult, she also ends up becoming diagnosed with ADHD, right? So acknowledging a lot of things that also may have been present in her childhood that were simply just going unaddressed, and not believed, not being heard or listened to at all. Um, she comes out as transgender in her mid-20s, and in our work together, she describes her experiences as having debilitating gender dysphoria, which is why I listed gender dysphoria on the list of disabilities, or disabling experiences on that previous slide. So she is having really, really intense chronic gender dysphoria and gender-related distress as she's coming out as transgender in her mid-20s. A few years after she comes out, she's able to start gender affirming hormones, which is an increasingly affirming experience and helps to decrease some of that distress, but doesn't take care of most of it, right? So she's still walking around and living in the world, um, really carrying a lot of distress with her every day. And unfortunately, she gets into an accident around 2018 or so, 2019, and she ends up breaking her back. It's a pretty serious injury. And in July of 2019, she ends up losing her job because she is not able to show up to work as consistently. She's experiencing a lot more chronic pain than usual. And this really is like a destabilizing event for her. So, Stephen, if we can go to the next slide, please. So I would really love, I have a few questions along the way for you all just to keep us all engaged together. Just from that information on that first slide, what disabling experiences do you already see that are impacting Julie so far in her life, in the first 30 years or so of her life? You can feel free to share in the chat if you're comfortable doing so. And even if you're not, I just want you to think about that. Just think about what kinds of experiences are overlapping for her that she's having to navigate every day. I'll just pause for a few minutes so folks can think and type.
This is Tiara speaking. Brody, we are receiving some comments via the Q&A function that says quality of life, mental health, and physical.
Yeah. Thank you, Tiara, for reading those. This is Brody again. Yeah, absolutely. Right. A lot of overlapping physical and mental health considerations and conditions that are absolutely affecting her quality of life, right? We already saw that she was managing as much as she could. She's doing the best she could. And that doesn't mean that her quality of life was very high or very strong. I believe she, at one point in our work together, especially with the gender dysphoria, but also I think this applies for all of the disabling experiences that she was navigating, attributed it to a vehicle that has like a 2 miles per gallon fuel efficiency, right? We're still able to go, we're still driving, but driving takes a lot of energy. And like even just operating the vehicle takes so much energy, right? That you're constantly having to fill up, or you're constantly starting to run on empty, right? Um, absolutely. Absolutely. So Stephen, let's go to the next slide to continue Julie's story. So I mentioned before she loses her job and has that backbreaking injury in 2019, and she is struggling with substance use this entire time. She decides as the end of 2019 approaches that she is going to make an effort to stop drinking. So Christmas Day 2019, she begins her sobriety journey and she starts attending Alcoholics Anonymous meetings as often as she's able to. At one point, she was going 5 to 7 days a week to have that consistency, to build that community, and to have the support that she needed to begin and especially to maintain her sobriety journey while navigating all of these other experiences. And about mid 2020, give or take, unfortunately, right in the middle of the beginning of the pandemic, Julie starts seeking trauma-focused therapy services. She wants to start addressing this chronic trauma that she is carrying with her. She gets connected with a therapist who specializes in EMDR, which is a trauma-focused therapy model. Um, and they work together for a few months, right? The therapeutic rapport is pretty positive. And a few months in, Julie shares with her therapist that she is starting the process to access gender affirming surgery and is going to need a letter from her therapist to support her efforts to do that. So she makes this request of her therapist that says, I need this letter. And then we can go to the next slide. This is where I want to poll you all. What do you think should have been the next thing that happened? And then also, what do you think did happen? You're welcome to share in the chat again as well.
This is Tiara speaking. Brody, just to clarify, the chat is disabled. Those looking to engage can use the Q&A function, and I will gladly read their responses. Thank you.
This is Brody. Thank you so much for letting me know that too. I'm just taking a look at the chat here also.
This is Tiara speaking. We have a comment that says counselor turned out to be transphobic. We have another comment that says, given that they're not currently with that provider, I assume the letter was not provided, although it 100% should have been. We have another comment that says she should have received the letter of support. What probably happened was she received questions and not full support.
Mm.
Someone else says affirmation and being curious about her experience. What happened? Patient was denied care and found you. Lots of comments coming in, Brody. Another comment, the therapist should have encouraged her and offered to write a letter. Someone else says denied, should test and applied. Um, they're coming in fast and furious, Brody. I don't know if you want me to continue reading.
This is Brody. No sweat. I appreciate you reading the ones that you did, and the ones that you did read are on the right track, right? Absolutely. What should have happened is the therapist she was working with should have done the letter assessment and done the assessment to make sure that she was prepared and ready to pursue gender affirming surgery, and then write the letter and support her in doing that. What did happen is a little bit different because this therapist truly, at the time, and still continues to be very trans affirming and very gender affirming. The problem that Julie ran into is that this therapist was a limited license therapist, which means that they're able to practice independently, but they do still have to have a supervisor that they report to, and they are like that oversees, right, their clinical services and experiences. And when that happens, at least in my experience, when you're writing gender affirming surgery letters, if you are a limited licensed therapist, your supervisor also has to sign off on that letter. So this therapist goes to her supervisor and says, "Hey, I have a client. She's looking for a gender affirming surgery letter from me. If I write it, will you sign off on it?" And her supervisor says no. Her supervisor says, "No, I will not sign off on this because this is outside of your scope of practice. And if you take on this client and you write this letter for her, it is a liability for you and it is a liability for me. It is not something that you are trained to do. No, if you write it, I won't sign it." And Julie would not be able to use that letter if it did not have her therapist's supervisor's signature on it. So this is one area, one of many, where Julie experiences that moment, right? That Dr. Katari mentioned before. Do I choose to continue working with this therapist, even though she can't give me this letter of support, but she is a trauma specialist and she is going to help me to heal this trauma so that my emotions are a little bit easier to manage and regulate. And maybe I can like continue feeling empowered and continue navigating life a little bit more smoothly? Or do I look for a different therapist who would be able to do this letter assessment for me? Right. And to this therapist's credit, she did give Julie referrals to see other therapists to have that letter be done and to continue their work. That is not what Julie wanted to do. Julie did not want to mess around. And that is the decision that a lot of clients make. If their therapist says, no, I can't do it, sometimes they do continue to see that therapist because they've been working together for a long time, but a lot of folks choose to work with somebody different. Um, or if they do continue to work with their initial therapist, they have to see a new person anyway and start all over and share all of their vulnerabilities and all of their experiences all over again, which is not a trauma-informed way of practicing. So Stephen, if we can move to the next slide, please. So what did happen, right? The initial therapist could not conduct the assessment. Um, Julie kickstarted a lot of different things in motion where she ended up working with me and still continues to work with me. And we have a really strong therapeutic rapport. She has gotten at least one letter from me for her gender affirming surgeries, if not more than that. Um, and that's been wonderful for her in terms of her gender identity, but I am not a gender specialist, or excuse me, I'm not a trauma specialist, is what I intended to say. I don't have certifications or extensive training in EMDR, right, or other trauma focused specialties that Julie also would really benefit from. Because in the meantime, yes, she's been able to access gender affirming surgery, and that's been really beneficial for her. It has decreased her gender dysphoria significantly. Um, but a lot of the other things that have happened, in my opinion, in the last couple of years that have impacted her mental health and impacted her ability to care for her physical and mental health needs relate from that unhealed and unresolved trauma. So navigating different relationships caused her to become unhoused a few different times in the last couple of years. This also has delayed her access to back surgery because she's not had a secure, stable place to live and recover from that surgery. Um, she has um, had a difficult time regulating things like anger or reactivity, which has, again, increased her exposure to law enforcement. And Dr. Katari mentioned that a lot of mental health um, institutions, like inpatient hospitals, are gendered or services are gendered. Jail is also very gendered. And when Julie has been incarcerated in jails for any length of time, almost every time she's been put in solitary confinement because they don't want to put her in the men's unit, they don't want to put her in a women's unit, so they put her in solitary confinement. And if you know anything about the effects mentally and emotionally of long-term solitary confinement on incarcerated people, it does not do any favors. It does much more harm than good. So every time she comes out of jail, she's kind of set back a little bit, right? And it takes a long time to readjust and to stabilize in order to continue the work that we've been doing. And for a variety of reasons, partly because of her housing instability, partially because of incarceration, and just being in chronic survival mode for 2 or 3 years at least, she has off and on lost contact with her providers. So managing her chronic pain has been inconsistent, managing her neurodivergence has been inconsistent, managing her mental health inconsistent. Um, Largely again due to other mental health concerns. Um, until recently, coming to therapy consistently was a challenge for her as well. Partially executive function and just remembering our sessions, and partially because she's in survival mode. And if therapy is not the most important thing, it's the thing that gets forgotten many times. Right? So there's so many different things that have been going on for this person that potentially, obviously, I can't see the future and I don't know everything that would have happened with certainty, but I imagine that some of these things may not have been quite as intense or may not have happened to the same extent if she had had that trauma treatment from the very beginning like she intended that was also affirming and able to support her in taking care of her gender dysphoria and taking care of her through that transgender identity lens as well. Next slide, please. I believe this is the last slide for our story today. Um, if there's anything that I really want to emphasize for you all to take away from my portion of this panel today, it's echoing a lot of what Dr. Katari said a little while ago, right? Access to trauma-focused therapy should also accommodate gender-affirming care, especially because we know that transgender and non-binary folks, whether it is childhood trauma or active ongoing trauma, they are likely navigating a variety of experiences that are traumatizing for them and may need that trauma-focused therapy lens that is also going to be affirming, right? So a lot of what providers can do is minimize the opportunities for patients to have to be in that position to choose things like that, right? Whether they're going to find a provider that is affirming for their identities or that is knowledgeable in the care that they need. You may have picked up on this, and I may have reiterated it a few different times now, but Julie's circumstances delayed her care for her physical well-being as well as her mental health, and it prolonged her suffering, right? Every single time that she needed to find different housing, every single time that she was approached by police, or every single time that she was reactive, right? Definitely accountability for our own actions and decisions. And she may have made different decisions if she had been given the tools sooner to do that more effectively, right? And helped her create those patterns earlier. And lastly, especially with the current climate that we are in, where transgender and non-binary folks in Michigan and across the country are at threat of losing access to healthcare, um, especially gender-affirming healthcare. Um, we all need to do the things that we can do to either advocate for more comprehensive care, or if you are a provider, to expand the care that you can provide, even if you don't use the skills very often, even if you are able to do one letter of support in 5 years, you are still helping one transgender person navigate this system that often is designed against them. Um, and if that means being able to care for their gender identities at the same time as supporting them and treating their physical or other mental health disabilities or other health and wellness needs, that is fantastic. We need so much more of that. Um, I believe that's all that I have for today. So we can go to the next slide, please. If you all have any questions for me, one last thing before I transition for Dr. Rowland to continue. Part of the work that I do is training other professionals to be able to do these letters of support for transgender and non-binary folks. So if you have any questions or if you're interested in chatting with me more about that, I know Dr. Rowland, it seems like that is the majority of the work that you do as well. Just want to add my name to the list of folks that you can reach out to if you are ever interested in any information in that area. So thank you so much.
This is Tiara speaking. Brody, thank you so much. That was a very enlightening presentation that shed light on the human cost of the access gap. One thing that's important for us all to remember as service providers is that our policies, practices, and procedures have real-world impacts on living, breathing people who deserve to be treated with thoughtful consideration along with dignity and respect. At this time, we are pleased to welcome Dr. Adrienne Rowland, who will give us some insight on how to do just that in her presentation on customer service principles in gender affirming care. Dr. Rowland is a fully licensed master social worker in the mental health field since 2004. She has a doctorate degree in clinical sexology through Modern Sex Therapy Institutes. Dr. Rowland has developed a comprehensive guide to queer affirming care for a secure web-based network that enables service agencies to coordinate care for residents. Welcome, Dr. Rowland.
This is Adrienne Roland. Thank you so much, Tiara. Let's see. Well, we can do next slide, please. Um, I am Dr. Adrienne Roland. My pronouns are she, her, hers. And as mentioned, I'm a clinical sexologist, social worker, and ASEC certified sex therapist and supervisor, as well as ASEC CE provider. I recently opened my own practice called Radiant Oak Sexual Health and Learning Center, and I'm super excited for what that will bring. Next slide, please. I think I already talked about this. I'm going to talk a little bit more about my doctoral project because this is the basis of the things that I will be talking about today. Primarily, my work is in private practice and in supervision. Next slide, please. I am a 52-year-old. Oh, I'm sorry. I forgot to share with you all about what you are seeing on the screen. So I am a light-skinned Caucasian, feminine presenting person with dark curly hair, rainbow-colored glasses. Behind me is artwork of a beautiful tree and then a black and white picture with a very colorful splash of rainbow. As my background, this is what my clients see. This is my home office. Apologize for not doing that earlier. I just want to position myself for just a moment. I am a 52-year-old white cisgender heterosexual female living in the Midwest United States. I have a PhD and have been working in the field for over 20 years. I recognize my position as privileged and have access to resources which are not available to everyone. In order to bring a more comprehensive view to my teaching, I strive to be humble and mindful of my privilege and seek to actively listen to those with a different lived experience. I do not seek to position myself as a spokesperson for any culture, race, sexuality, gender expression, or identity, or any intersections of those categories. My training curriculum was developed utilizing evidence-based research and educational resources, as well as support from a community advisory committee made up of transgender and gender diverse people. These people gave so generously of their time, energy, suggestions, and honest feedback. And I understand the importance of nothing for the people without the people. And as a cisgender person, I know that I cannot know exactly how my work will be received, nor can I accurately represent the needs of a community without input from those within it. So I acknowledge this and I welcome discourse, suggestions, corrections, objections, additions, and hopefully collaboration. Next slide, please. For my doctoral project in clinical sexology, I created a gender-affirming care curriculum for medical and mental health providers, including all staff who work within a medical and mental health setting. The purpose of the program is to improve knowledge about transgender and gender nonconforming patients and reduce implicit bias among practitioners and provide tangible, practical applications. This curriculum was designed to be a 20 to 24-hour training over 4 different modules. Today, I will be focusing on the 4th module, practical applications, and will provide just a few key points to consider when providing affirming care. This content mainly focuses on care for transgender or gender diverse folks. However, it can apply to almost everyone under the LGBTQ plus umbrella. Next slide, please. The Institute of Medicine's 2001 report, Crossing the Quality Chasm, a New Health System for the 21st Century, called for a fundamental redesign of the US healthcare system to improve quality and better meet patients' needs. They identified 6 aims for improvement. Healthcare should be safe, meaning it should avoid harm to patients. It should be effective, based on scientific knowledge, patient-centered, respectful and responsive to individual preferences. It should be timely, reducing waits and harmful delays. It should be efficient, avoiding waste of resources, and it should be equitable, providing care that does not vary in quality by personal characteristics. I'm going to focus more specifically on a health equity framework. Next slide, please. Number 1, make health equity a strategic priority. The main point of this is that change needs to start at the top with leadership and their commitment to health equity and the ability to secure adequate funding to help keep people healthy. This can be done by building it into the executive compensation plan and the organization's business plan. Sustainable funding needs to be secured through payment systems at both the federal and state level, which I recognize is very, very difficult at this time. Incentivized to keep people healthy as opposed to focusing on volume and addressing healthcare issues after people become sick. Number 2 is to develop structure and processes to support health equity work. Ensure that there is a structure in place to continually oversee and manage ongoing health equity work. This can be done by establishing a committee to govern, oversee, and manage equity work throughout the entire organization. Resources in the organization's budget need to be in place to support equity work. Number 3 is to address the multiple determinants of health. Focus on strategies where healthcare organizations can have a direct impact on specific determinants of health. For healthcare, focus on populations with worse healthcare outcomes and consider available resources to those particular populations. Establish trust between providers and patients. Provide accessible primary care for marginalized individuals in the community. With regards to socioeconomic status, provide economic and development opportunities for all levels of staff. Encourage procurement of women and minority-owned suppliers. Build healthcare facilities in underserved communities. For the physical environment, decrease medical waste and pollution. Improve the local neighborhood through sponsoring community spaces, parks, and walking trails. Develop community investment programs. And with regards to healthy behaviors, start with helping the organization's employees get healthier through healthcare coaching, health risk appraisals, and health insurance benefits. Partner with local food banks and organizations to provide healthy food opportunities for the community. When an organization focuses on populations that have worse healthcare outcomes, those with better healthcare outcomes will also benefit. Focus on increasing support for minority employees and suppliers and put healthcare facilities in underserved communities to increase direct impact. Decreasing medical waste and pollution while sponsoring community development programs will improve the neighborhoods where the facilities are located. And finally, when employees are inspired and healthier, they will help their patients and the community in general. Number 4 is to decrease institutional inequities, such as racism and implicit bias. Organizations need to understand in what ways they contribute to institutional racism and other forms of inequity. Organizations need to examine their physical space with regards to accessibility, parking, cleanliness, waiting time, decor, design of the building, and provision of care services in newer facilities. Consider which insurance plans a healthcare system contracts and how that may impact access to marginalized patients. Medicaid pays less than Medicare or private insurance. Help patients understand their options with regards to health insurance. Reduce implicit bias within organizations' policies, structures, and norms, as well as within patient care. Reducing racism and implicit bias is a critical need for health equity. This concept does not stop with the individual practitioner or medical personnel, but needs to happen at the organizational and structural level. And number 5 is to develop partnerships with community organizations. Connect with community partners who are familiar with the needs of marginalized populations to address determinants of health that are beyond the reach of the healthcare organizations. Invest in financial contributions to community programs to improve health outside the healthcare setting. Next slide, please. Here are 7 ways that the physical space of a medical or mental health practice, regardless of the type of practice, can be experienced as safe and welcoming. And some of these things have already been mentioned, and so it may be review, which I think is just great for internalizing information. Number 1, first and foremost, it's very important for front desk staff, support staff, and all other staff who are on the front lines and have patient interactions to receive training on gender affirming care and on working with LGBTQ clients, because they are often the first line of contact with a patient. Number 2, waiting areas need to include items that indicate a commitment to serving the LGBTQ population. and the transgender and gender diverse population through posters, artwork, magazines, and pamphlets that are specifically about transgender and LGBTQ health. Number 3, bathrooms need to be marked as gender neutral or indicate that a patient may choose either the women's or men's rooms based on their own preference. If this is the case, it is important to make at least one bathroom gender neutral. This will be supportive and helpful for patients who are non-binary or who are not comfortable in a gendered space. Number 4, modifying a practitioner or clinic's website to include gender-affirming specialties and to assure that transgender and gender diverse patients and LGBTQ clients know they will be treated respectfully is an effective way of creating a safe and welcoming environment. It's not enough just to know that you have to specifically and explicitly say that you are affirming. Number 5, also making sure that forms and documentation, as well as electronic medical records, are gender affirming is critically important. Unfortunately, we don't have time to go into details about how this can be done. However, I'd be happy to provide further consultation or training in this area. Dr. Katari mentioned that earlier about, maybe stating that sex is necessary for insurance purposes, and then they get to pick their gender. Number 6, it's really important to avoid inadvertently, quote, outing patients when you are retrieving them from the waiting room or speaking to them at the front desk. This can happen if the patient's name or gender identity does not match their insurance or medical records. You can cross-check identification by asking for a birth date or address as opposed to asking if the record may be under a different name. Staff could also use the patient's last name when calling them back to a treatment room to avoid using a name that may not be the client's chosen name. In addition, calling a transgender or gender diverse patient by non-preferred pronouns discloses their personal identity to those around them in the waiting room, which creates an uncomfortable environment and could be very upsetting or triggering for the patient. Remember that misgendering gives other people permission to do the same, and that is never okay. And number 7, healthcare practitioners need to be explicit and honest about limits in their knowledge and experience in working with trans patients. Having available referrals and resources to other providers for specialized care is critical in providing good continuity of care. I love what Brody said, get some training so that you can provide that service and at the very least know when to refer if you cannot. Next slide, please. So there are 4 specific ways an organization can create a culture of supportive and accountable teamwork. Number 1 is to provide an environment of care that allows trans patients to feel safe, included, and welcome. It's really important for staff to be trained annually around culturally affirming communication with transgender and gender diverse patients, and new staff members need to be trained immediately upon hire. We know that things are changing all the time, so it's not a one and done. Number 2, having a clear line of referral for staff members and patients to file a complaint if they witness or experience discrimination is really important and a very important aspect of an accountable workplace. There needs to be someone that someone can turn to that will be accountable. Number 3, this can be helped by designating one staff member to be responsible to provide guidance, develop policies and processes, and check in with staff regularly to offer a space to voice questions or concerns in a non-judgmental environment. And number 4, it's very important to have policies that hold staff accountable for negative or discriminatory comments or actions against trans folks or LGBTQ folks or disabled folks, anyone. The CDC recommends including the term, quote, gender identity and expression, end quote, in non-discrimination policies and post these policies in visible places, such as on websites, waiting rooms, on promotional materials, and or registration forms. And having someone that can be held accountable or can hold others accountable designated is really important because you have to be able to give them the power to make decisions and to impose consequences or provide further learning opportunities. Next slide, please. Practitioners who work with transgender and gender diverse patients should get involved in trans communities. Listed on this slide are some of the main benefits of strong community engagement. Number one, position trans communities as experts in their own healthcare. Because trans health has been pathologizing and often viewed as paternalistic, clinicians often view them as disordered and try to discourage them from being trans or are refused care for not being, quote, trans enough. Trans people have been, until recently, excluded from contributing to knowledge production of trans health. To prevent hermeneutical, it's a tough word, um, injustice, defined as a socially disadvantaged group is being left out of knowledge production about themselves. Clinicians need to engage in trans communities on their own terms and position them as knowers within their own therapeutic life. Research shows that the clinician-patient relationship is a strong predictor of clinical outcomes. If a patient expects to be mistreated or denied services, they are less likely to seek care, as Dr. Katari showed. Number two, foster strong therapeutic relationships. Engaging with trans communities outside of the clinic setting fosters trust. Again, because trans people have been largely left out of providing knowledge about themselves, there is a lot of missing information. Number three, engaging with the trans community provides an opportunity to gain much needed knowledge, evolve along with them, and learn how to best meet their needs. Number four, community engagement responds to social and political determinants of health. Best practices in trans health are controversial on a socio-political level. Significant efforts are being made to limit or remove protections for trans and gender diverse people. As of June 1st of this year, there are 910 anti-trans bills across 49 states. 103 anti-trans bills have been passed so far this year. Clinicians are in a good place to amplify trans voices because their credentials and education give them social authority. Engagement with trans communities must be done with humbleness and the knowledge that the clinician does not know everything about the community. Humility entails decentering ourselves, deferring to trans perspectives, and resisting the urge to inject cisnormative views, technical jargon, and medicalized perspectives into community spaces. Next slide, please. That's all I have for you. Like I said, that was a very, very brief snapshot of one module of a larger training. And I would love to provide more information. This is how you can get a hold of me. Thank you so much for your time.
This is Tiara speaking. Dr. Rowland, thank you for that presentation. There are so many times that we highlight the problem with no tangible action steps for solutions. So I'm sure mental health care providers will find great value in the information that you shared. Right now, I would like to invite our entire panel to turn on their cameras for a brief discussion. We have some predetermined questions that we would like to ask, but we also welcome the audience to submit any questions for our presenters using the Q&A function. I will kick off this discussion with the first question to all presenters. In your professional career as a practitioner, was there any formal training offered or required in providing accessible and equitable services to LGBTQIA2S plus patients? Also, what steps can be taken to ensure that healthcare providers across the state are trained in culturally competent care? This is Tiara speaking. I am not seeing Dr. Katari on screen. I hope that they are still with us, but I'm not sure if Brody or Adrian, you would like to answer that question?
This is Brody. I can go ahead and start. It looks like Dr. Katari just popped out for a second. Um, Hopefully they can come back soon. Um, I know from my experience in my undergraduate program and my graduate program, I did not get any formal training to work with trans and non-binary folks or the LGBT community The honestly, the only specific education and training that I did get was from Dr. Katari. I was privileged enough to be in one of the like introductory graduate courses with them my first semester, and then I also took their sexuality and social work course. And because of who they are and what they do, it like the curriculum was really infused with supporting members of the LGBT community and also disabled folks, especially from like a sexual lens and a sexual healthcare lens. The only reason that I learned how to do the work that I do is because I pushed for it in my field placement. And I was lucky enough to have supervisors who saw that drive and that desire in me and really empowered me to learn and empowered me to build those skills and signed off on my WPATH letters and helped me to design the assessments that I use for all of my clients who need letters of support. But I imagine that my experience would have been very similar to the therapist in my case study if I had had any different supervisors when I was a student.
This is Tiara speaking. Thank you so much for sharing, Brody. I will rephrase the question for Shanna, who has just joined us again. Welcome back. The question was, in your professional career as a practitioner, was there any formal training offered or required in providing accessible and equitable services to LGBTQIA2S plus patients? Also, what steps can be taken to ensure that healthcare providers across the state are trained in culturally competent care?
This is Shanna. Apologies, my computer crashed, but I'm back. Um, so my master's is actually in human sexuality education. I am a professional pervert by trade, um, as well as an ASECT certified sexuality educator. And so much of my program focused on these topics. However, this was in the early aughts or mid aughts, and a lot of it was really focused on deficits, right? So HIV rates in gay male communities, the horrible challenges of transgender people, and suicide rates, and how hard it is for them to get jobs and all of this. And so, I had a lot of that training, but it was really negative, and it was really only focused on, when something went wrong. And so I think something that I really encourage folks to do is to think about not only strength based, but and Dr. Rowland spoke to this, but really community created trainings. And one of the things I've recently done is work with Transcend the Binary to create a virtual peer support specialist led intervention called Trans Wellness, Trans Brilliance. And Brody was actually, part of supporting that work as well. That is where we train members in their own communities to lead these wellness and mindfulness groups. To really empower one another rather than having, the specialists come in from the outside and tell people what they need to know and what they need to do. I really think that focusing CEs not only on just modalities. I think it's hard because a lot of people are like, well, yeah, I want to get trained in EMDR and IFS and DBT and all of these letters and acronyms that none of you, if you don't know what they mean, really need to know unless that's an area of interest. But we forget about how do we get trained in cultural responsiveness. And also, just because you learned how to treat trans people once 15 years ago doesn't mean it's the same. There's been huge changes as we've moved from, different standards of care towards informed consent, for example, has been a really big shift. Um, so, I think looking for continuing education, looking for intersectional continuing education, today we're really focusing on the intersection of disability and queerness and transness. But also, as many of us have brought up, there's all of these other pieces, right? Like race plays a huge role in this as well. Age plays a huge role, the experiences of queer and trans folks in their 80s. We're seeing a lot of people trying to decide if they should go back into the closet in order to be safe in aging spaces. Youth, right? Like stuff around gender and queer, like I learn new terms every day because youth are so creative and scrappy and coming up with these things. And so thinking about how do we engage at these intersections? How do we go to trainings that are hosted by members of the community? Um, and then, honestly, this is, Brody spoke to this a little bit in talking about, writing letters. But we are at a point in our society where you just write the letter. I think, people get really caught up in diagnosing things. Is this the right thing? But the thing is that gender dysphoria is the only thing in the DSM that can be like fixed or cured by medical intervention, right? And not all trans people experience gender dysphoria, and not all trans people who experience gender dysphoria, most of them don't continue to experience it once they're able to get access to the medications and surgeries that they want so that their body is more in aligned with how they view it. There's very few reasons not to write the letter. And so I think, people get so worried and so anxious about what the right thing to do is. And the right thing is to give people that empowerment to access the care that they want. So I know that kind of deviates a little bit from the question you asked, but that's the one thing I hope everybody takes home from this is like, we don't ask people to get letters if they want to have a breast enhancement if they're cisgender. We don't ask cisgender men who have low testosterone to get a letter written in order to get, testosterone cream. We don't ask cisgender women who are going through menopause to get a letter to get HRT, right? You can actually get it on the internet through a virtual doctor at this point. So why are we making things so different and so difficult for trans people?
This is Tiara speaking. Thank you both so much for sharing. Shannon, we also received a question via the Q&A regarding the survey. Do you mind restating the website where people can find the survey?
Yes, the survey is just at mitranshealthsurvey.com. And if you have any questions about it, you can also email me at skattari, so SKATTARI at umich.edu.
This is Tiara speaking. Thank you so much. I'm going to go to another question from the audience. This question says, with the discrimination experienced in accessing medical care, was there any information obtained to address discrimination experienced when and if a patient seeks health care for an ectopic pregnancy?
This is Shanna. I'm assuming that was directed at me. We didn't ask that specifically in that survey. And separately, I don't actually know if anybody's asked specifically about ectopic pregnancies, but this is a huge issue for non-binary, queer, and transmasculine folks who may have bodies that have uteruses and may be getting pregnant intentionally and dealing with an ectopic pregnancy, but also may be getting pregnant not intentionally and not even know that they are pregnant. And again, if somebody who is masculine presenting goes to the ER and has, pains and cramps, if they are read as a man and we're not asking questions about what body parts you have, they may, oh, it's appendicitis or it must be a stomach issue, and ectopic pregnancy wouldn't even be considered. And so, this is one of these challenges that we run into is people get documentation that supports who they are, which is wonderful. But then when physicians make assumptions on body parts, and that goes for everyone, right? Like there's cisgender women who have had hysterectomies and still have to take urine tests in the emergency department because they're like, but you might be pregnant. So instead asking, again, open-ended questions like, is there a possibility you could be pregnant, or do you have a working uterus, is much more effective than saying things like, oh, you're a woman, it must be a pregnancy, or you're a man, it must not be. And if you're interested in research on this, feel free to email me and let's talk.
This is Tiara speaking. Thank you again for that answer, Shanna. I also want to highlight the Michigan Department of Civil Rights, which is the operational arm of the Michigan Civil Rights Commission. Our mission is to investigate alleged discrimination and to secure the equal protection of civil rights. And we fulfill this mission by investigating and resolving complaints of discrimination and promoting voluntary compliance with civil rights laws. So if there are people who believe that they have experienced discrimination due to one of the covered bases, which include things such as disability and sex discrimination, they can contact our enforcement division to file a complaint. With that said, I will move on to the next question from the audience. Can you define the types of discrimination reported? I believe this was also addressed to you, Shanna. It says also, is there a documented breakdown of reported disabilities as the percentage is so high? Shanna, this is Tiara speaking. You are muted.
This is Shanna. Thank you. I'm pulling up the transcript to make sure because I can't see the question since I rebooted. Experience discrimination. Types of discrimination reported. I'm not sure what the question is about types of discrimination reported. We looked at a variety of different spaces. And so, for example, with the the University of Michigan survey, we looked at different spots on campus, not just the ones I reported, but also at the registrar's office and in the classroom and that type of thing. In the Michigan Trans Health Survey of 2018, we looked at a variety of different locations. So mental health providers, domestic violence shelters, rape crisis centers, pharmacies, emergency departments, ambulances and EMTs, primary care providers, all dentists, all of that. And we're looking at several more options with the 2025 survey as well. As far as breakdowns around disabilities, I don't have them off the top of my head, but I'm happy to, if you email me, I'm happy to give more information. We see really high rates, not surprisingly, of neurodivergence, so autism, ADHD, ADHD. For folks who don't know, about 40% of LGBTQIA2S plus individuals identify with an autistic, ADHD, OCD, or other neurodivergent diagnosis, and about 40% of people who are neurodivergent. I think the latest research is coming out. It's closer to 60% of people who identify as neurodivergent also identify as LGBTQIA2S plus, right? So it's like a very overlapping Venn diagram, and I can go into that for other things. But we also saw a lot of chronic illness and a lot of chronic pain. And what's interesting as we're moving forward too is for folks who don't know, queer and trans folks, like folks of color and low income folks, are disproportionately impacted by COVID and also disproportionately impacted by long COVID. And so right now in the US, for example, 1 in 5, this report just came out last week, 1 in 5 of all adults has some issue related to post-COVID sequelae. So that's 20% of the US population of adults has some, not necessarily a long COVID diagnosis, but may have cardiac or lung or other issues, brain fog related to their COVID infection. And it is much higher amongst trans and gender diverse people, closer to the like 40 to 50% range. So we're seeing, again, a lot of chronic pain, a lot of chronic illness, a lot of neurodivergence. And then other types of socio-emotional, which, I would maybe put under neurodivergence as well, but I can give breakdowns if people are interested. And also, just to be clear, like a lot of it is multiple types of disabilities. So that's where we see somebody who has like autism and depression, or a mobility disability and general anxiety disorder. So it doesn't tend to be, people don't tend to fit into individual categories as much.
This is Tiara speaking. Thank you. I believe this next question was posed during Brody's presentation, but any of our panelists are welcome to chime in. The question is, what are typical insurance company requirements prior to approval of gender affirming care surgery? It says, just curious, not knowledgeable. My insurance company always tells me I have to try this, then that, and then this, maybe to get an MRI or surgery. So Brody, I will throw that one to you first.
This is Brody. Typically speaking, insurance companies, I mean, obviously it depends on the company and what their like covered member benefits are in general, but then also for that person's specific plan. My understanding for the most part is insurance companies refer to something called the WPATH standards. WPATH is the World Professional Association for Transgender Health, and they set a standard of care for what conditions need to be met for a person to be essentially like ready for surgery. Ready, I use in quotation marks. Um, And there's pros and cons to having that and using that, but most insurance companies refer to that standard and they say whatever the WPATH standards are is what needs to be met. A lot of any prior authorizations will be on the doctor or the surgeon's end of things. So they would take that letter and then submit a prior authorization to the insurance company to say, hey, this person wants gender affirming surgery. We have this letter saying that they qualify. And then basically anything applies after that. What I will say is different insurance companies don't always follow WPATH standards, or if they do, it's not always the most updated version. So the most accurate up-to-date version was published in, I believe, December of 2022. Before that, it wasn't reviewed and revised since 2011. So it had been 11 years since it had been revised at all or updated. Um, but some insurance companies use the standards that are in the 2011 version or the one that was before the 2011 version, where there's pretty significant changes in terms of what is required from a patient. Right now, you only need one letter of support from one person for any one surgery. Previous standards said you needed one surgery letter for either a breast augmentation or a double mastectomy to remove breast tissue, and two letters from two different mental health professionals to do any kind of gonadectomy, so removing um, like reproductive organs essentially, or creating different ones. So that would be phalloplasty, metoidioplasty, vaginoplasty, hysterectomy, orchiectomy, oophorectomy, anything regarding genitals needed two letters. Some insurance companies follow that rule. Some say, nope, you need three. You need one from your PCP and two from two different therapists, right? So it really is company specific. It should be the 2022 standards, and it shouldn't be that arduous of a process, especially because the current standards are much more accessible. That doesn't mean that they will be. So it does depend, I think, on that. And I know a lot of Medicaid plans are under threat right now with the House Bill 1 being passed, and it's under review of the Senate, where Medicaid, I believe also Medicare plans and plans under the Affordable Care Act will no longer cover gender affirming care for adults, not just for minors, but for adults as well. That is more state specific, where certain states have explicit protections saying insurance companies cannot discriminate against those kinds of medical interventions. And right now, Michigan is one of those, but that does not mean it will be that way forever. So it really is important to stay up on what the laws say in the states that you're in, and to know what stances different politicians who are running for office are running on so that you can vote in the way that aligns with your values as best as possible.
This is Tiara speaking. Thank you, Brody. Adrian, I saw you nodding in agreement. Would you like to
Mhm.
add to that?
I would. This is Adrienne. Thank you. I want to echo something that Brody said about your individual insurance plan. Um, being a very important factor, and I have a little story to go along with that. So, not only is it important to know if your insurance covers gender affirming care, but if your particular plan that your either employer or you have are subscribed under, because I have a client that I'm working with right now who was approved for gender affirming care, for gender affirming surgery, specifically a hysterectomy, and was assured by the insurance company, yes, your plan is covered or covers this. You will only have to fulfill this aspect of your deductible. This is the code that the doctor, the surgeon will need to bill under, and they did all of that. And they were assured more than once that this was going to be covered and it fit within their plan. And they had surgery and recovered. And 3 months later, literally this week, just got a denial from their insurance company and said, oh, no, your plan doesn't cover this. And I was actually, they happened to be in session with me when they got the phone call. And so I got to hear their conversation with their insurance company and said, so what are you telling me? You know, I was told this was covered. No, unfortunately, and they had the name of the person. I spoke with so and so, and they said this was would be covered. And they said, no, I'm sorry, your plan doesn't cover this. And your insurance in general doesn't cover this, even though, do I need to submit a different code? Does the doctor need to submit a different code? No, this won't be covered. You can appeal, but you probably will be getting a bill for over $60,000 post-surgery. I mean, we can't put the stuff back. And this was very medically necessary, and it was very well documented. This was a case where this person needed two letters from mental health providers, according to the insurance. And um, so, yeah, some insurance companies will cover it. However, I think you want to be sure and then double sure and then triple sure. And this has happened more than once, unfortunately, with clients of mine. And it's 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 devastating. I mean, you can only imagine what my client is experiencing right now. And my hope is that they are going to, and I will help in any way that I can, to affirm what they are needing. But it's incredible what people have to go through to get the medical health needs met.
This is Tiara speaking. Wow, thank you so much for sharing. Um, we do have another question from the audience that is open for answering by any of our panelists. Is there a listing of gender affirming providers that we can access so that we can connect clients to care?
This is Brody speaking. I actually have a couple in mind, especially for folks who are living in Michigan. The Transgender Michigan website is a really great resource. Essentially, they have a resource on their website called the Trans Index, I believe, or Trans Pages, and it is a listing alphabetically of a variety of different kinds of services, not just medical or mental health services, but things like acupuncturists or tattoo artists, and bicycling clubs and writing clubs and like all these different like groups and organizations that are either trans affirming or specifically for trans and non-binary folks. And they have listings by county in Michigan of therapists and doctors and surgeons and primary care doctors. And endocrinologists, etc. I like that resource because it is opt-in. It's not like the folks at Transgender Michigan are just like looking on different sites and saying, "Oh, that person looks nice." It's like you have to contact them as a provider to say, "I want to be added to this list." So it's a little bit more certain and guaranteed that the provider is going to be affirming. Um, there's that one. If folks need specifically or exclusively letters to access surgery, Gallup, the Gallup Project, GALAP is another good resource. I don't think that that is specifically for Michigan, but you can filter providers by state. And that is also opt-in. So therapists need to contact Gallup to say, I want to be part of this project that helps to make accessing affirming letters of support much more accessible. So those are two places that I would direct folks to look.
This is Tiara speaking. Thank you all so much for sharing. I see that Shanna wants to add to that as well.
This is Shanna. The other thing that I would say too is that there are practices that are known in this state for being specifically trans affirming. And this is one of the benefits of COVID. One of the few benefits is that telehealth has become much more normalized, which also makes things much more accessible for folks with chronic illness and chronic pain, mobility related needs, transit related needs, anxiety. Um, Neurodivergent folks can all access care from the comfort of their own home. And you can see anybody in the state of Michigan, regardless of where you are at. And so Connolly Counseling is specifically really great for LGBTQIA2S plus folks and youth and neurodivergent folks. Hearthstone, which is based out of Grand Rapids, I think, is all neurodivergent, and they're very trans affirming. The Center for Radical Wellbeing is very trans affirming. Anybody there. Integrative Empowerment Group is very trans affirming. Amplify Collectivo is a organization of all therapists of color that are also all queer and trans affirming. Wild Fern Wellness is based out of Lansing, but again, people are seen from across the state. Affirmations also has counseling that's based out of Detroit. And so again, like, you know, there's individual folks who will put themselves on these lists. And, you know, I used to run a list like this in Colorado and had people email me individually. And, you know, this was in the early 2010s. And there were, you know, a couple dozen people in the whole state. And I think we're really lucky now that I could name off the top of my head over 100 trans affirming therapists in the state. It helps that I, you know, have taught a lot of them, but, you know, so we're really, really lucky, particularly in a state like Michigan, which people, you know, it's not seen necessarily as a really progressive state, that we have really great affirming practitioners. And something that I'll mention right now too is that with other states around us putting in gender affirming care bans for young people, we are seeing a huge influx of folks coming to our state for care, both for mental health care and for you know, the medical side of things. And so if you are a practitioner yourself, it is likely that you'll see what we're calling gender refugees, of folks who are crossing borders in order to access care as well.
This is Tara speaking. Thank you so much for sharing, and thank you all for sharing those resources. I'm sure that many people will find them very valuable. I do have to note that as a government organization, MDCR does not endorse any particular medical provider or a specific resource for healthcare. So just putting that out there. Next question from the audience. If you guys give me 1 second. See. This question reads, it seems to me that gender dysphoria is a legitimate health concern. I feel it's important to try and explain this to others, but I'm concerned that using terms like disability or mental illness could end up creating even more stigma. Do you have any advice on how to navigate this?
This is Adrienne. I could certainly speak to that briefly. It's such a tough balance to navigate when you talk about diagnoses. You know, we have the DSM-5, which is the Diagnostic Statistical Manual that we use to access care, help people access care, and gender dysphoria is in there, and that's very controversial because on the one hand, it is saying it's a disability or it's a mental health issue, when the reality is that folks that experience gender dysphoria do so because, in large part, because of society's um, lack of inclusivity, society's judgment, and that is what causes harm. And so for us providers who do have to, in some cases, diagnose gender dysphoria so that people can access care, right? Like there has to be one of the criteria for gender affirming care is a diagnosis of gender dysphoria. You need to demonstrate that there is a significant impact to qualify for care. We have to be really careful to say, like, we do not believe that you are a problem or you are bad or wrong. We are creating this or giving you this diagnosis so that you can access the care that you need. We are hoping that will continue to shift and change. So I think when you talk about gender dysphoria as being a real problem, really being able to talk about it in terms of because of the discrimination that folks experience by the society, that is what is causing harm. And so being inclusive, being affirming, being supportive, that is what is going to reduce in a lot of ways the harm and the symptoms of dysphoria.
This is Tiara speaking. Thank you so much for that, Adrian. I do have a comment from a member of the audience that says local pride centers often also keep affirming provider lists, such as the Grand Rapids Pride Center, and can refer to more local services. So thank you for that comment. Another question from the audience. I believe this one was posed during Dr. Rowland's presentation regarding the bills that were passed. It says, was that static 910 bills over 46 states?
That was 910 bills across, I believe I said 48 states, 48 or 49 states. I can go back to my notes. That came 40, was it 49? That came from, I'm trying to find the website. That comes from, sorry, I will put the website in the chat that came from. It's a website that tracks the bills across the state or across the United States. I'm having a hard time finding it here real quick.
This is Tiara speaking. Thank you so much for sharing that, Adrian. And we will be sure to include all of the links that you all shared and the sites that you have referenced in the follow-up information to participants. While you are searching for that, Adrian, we also had a question about contacting you regarding the module for those who are interested. How would they contact you?
Email is the best way to get a hold of me. So that is adrianroland68@gmail.com. And that is on, I believe, the last slide of my presentation, my part of the presentation. Yeah, that is the best way of getting a hold of me, and I can get right back to you. And I did find that website. So it is www.translegislation.com. And
This is
that's updated regularly.
Thank you so much. For our other panelists, what is the best way that folks can contact you all should they want to follow up or engage? Shanna.
So this is Shanna. I've been having lots of computer trouble. You can contact me, as I said, at skatari@umich.edu. You can also visit my website, shannakatari.com. While I have my mic off, I just wanted to answer the question too about, disability and mental illness and stigma. And a couple of things here is that I was part of this really big conversation when we were moving from the DSM-4 to the DSM-5 about, it used to be called gender identity disorder. Do we include that? There's a decision to switch for gender dysphoria. And there were a lot of camps that were having different conversations. And a really strong group was like, we don't want any of this in the DSM because being trans isn't a mental illness. It isn't an issue. Trans people have always existed. We will always exist. Every culture that has existed has had people that gender exists outside of whatever binary they've created, right? And so, but the biggest group that was speaking was like, but if we don't have access to a diagnosis, we can't have access to insurance covering care. And as Dr. Rowland pointed out, that doesn't always even work. Back in Colorado, my partner did work for the state org, and he would always say, appeal, 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 because insurance companies are going to turn you down. And if you can run out their appeals process, you usually can get it covered eventually, but the amount of labor that you have to do is massive, right? And so gender dysphoria was chosen to be included, despite, again, it's the fact that it is not a mental health issue, so that people could access care. So I just wanted to give a little history around that. The other piece, though, is that we also need to do a lot of work pushing back against the stigma and ableism around disability and mental illness as a whole, because there is a lot of mental illness generally in our population. There is a lot of mental illness in the trans community. I want to be very clear, and I didn't say it during my presentation, but trans people are not inherently more depressed or more anxious than the general population. We are more depressed and more anxious because of transphobia and because of the things we experience in this world, right? And the same is true for disabled folks, for neurodivergent folks, for chronically ill folks, is that living in a world that literally says you don't belong here, whether it is saying that out loud, or I think about, going to a building where there's not an elevator, there's no accessible parking. I'm immunocompromised, and because people don't mask, I can't really leave my house. I teach online, I do these presentations online, I speak around the world from the comfort of my home because people are not willing to, make spaces where folks like me can exist. And so we really also need to push back on that stigma that, disability is just a natural part of human diversity, including mental health concerns. And so many of our mental health concerns are a direct correlation to experiences of oppression, whether that's racism, ableism, transphobia, queerphobia, etc. So thanks for letting me use my time for that.
This is Tiara speaking. That was very powerful. Thank you so much for sharing that, Shanna. We do have another question from the audience. It says, can anyone from the panel speak to what collaborations or partnerships as a practitioner have you had with civil rights attorneys via advocating and supporting patients or clients? Do we have any takers for that one?
This
Okay.
is sorry, this is Brody speaking. I don't have any direct relationships with legal counsel. Unfortunately, I would love that. Especially when it comes to like supporting and appealing for civil rights concerns or discrimination concerns. Um, I believe the person that I'm thinking of is specific to Michigan. I believe he works for the ACLU. His name is Jay Kaplan. He is well known, I think, in the community as well. And I know that a lot of folks that I've worked with who need more like legal advocacy or legal support often start with Jay's office because he's known for being such an advocate and working tirelessly, not just one-on-one to support like civil rights concerns and discrimination concerns, but additionally advocating on a state legislation level to pass either to support and pass supportive and protective legislation for LGBT folks but also to speak out against proposed legislation that could harm us and take our rights away. So that's one place that I can definitely start referring folks to, but I don't have anybody in addition to him, unfortunately, right now.
This is Tara speaking. Thank you so much for that, Brody. Another question from the audience. It says, I work in a community mental health agency. We have requested that our PIHP require SOGIE diverse trainings. Hopefully, you all know what that means because I don't. It says they have declined, stating that the state of Michigan does not require it, therefore, they cannot require it either. Are there efforts to advocate that LGBTQ plus trainings are mandated for our state with MDHHS? And I will request that if any of you are to answer that, can you please explain for the rest of us who may not understand those acronyms what those mean? Thank you.
I'd be happy to. So what they're referring to is SOGI, sexual orientation and gender identity information, and that is it's a standard of care for medical health records, electronic health records to help capture both sexual identity and gender identity, or sexual orientation and gender identity, for folks to be able to provide affirming care. It's best practices. Whether or not efforts are being made to enforce it or require it, that I don't know because I don't work for DHHS. I'm in private practice, thankfully, so I can do that for myself. But basically, to be able to let somebody share with you sex assigned at birth, which provides one set of information, and then gender identity, which provides a whole nother set of information that can be available for people across the practice. Like I said in my training or my portion, that it's so important from the front office staff who is initially greeting the client all the way to the medical records or billing department who may have to make a phone call, that they are not misgendering folks, they're not inadvertently outing folks, and that helps give that assurance.
This is Tiara speaking. Thank you so much for that, Adrian. I'm going to move into rapid fire mode because we are running out of time and we have quite a few questions left in the Q&A function. This question is, considering the potential changes to Medicaid or Medicare, I've been getting questions about how to access HRT without insurance. Any suggestions or information? If I can have one panelist answer. Shanna? Are you not able to unmute? Let's see if we can assist with that. Are you able to unmute now? No. Okay. Let's see. I'm not sure why that is. Let's see if we can troubleshoot that really quickly. Still not working. My apologies. Does anyone else want to answer that one by chance?
I don't know that I have as good of an answer that Shanna would have given, but as Shanna mentioned before, there are online hormone companies that do provide hormone services. Um, I think what is most important, just a cautionary, just being very careful because it's not uncommon for folks to get hormones, from other countries or on the black market and things like that, and just being very, very careful because it can do harm, to your health. And so having knowledge and trying to utilize a knowledgeable provider. But a lot of those online platforms do not require insurance, even though they are costly.
This is Tiara speaking. Thank you so much. I'm also receiving feedback from audience members saying Point of Pride is a good source for HRT access information. I'm also seeing some shout outs to Jay Kaplan of ACLU Michigan, and also Emma Zanotti of Equality Michigan, who someone describes as trans herself and fierce. Sorry, these comments are shifting as I'm trying to read them. Um,
This
this,
is Brody. I just have one more, also from Shanna. Planned Parenthood is one resource where folks can access HRT if they're underinsured or if they do not have insurance. Plume is also another resource. It's a virtual, what am I saying? Virtual doctors and professionals who can provide gender affirming hormones virtually. So there's not like a location. It is a website that you can use, and I think some of those services can be costly, but they are available for folks who don't have insurance.
this is Tiara speaking. Thank you. We have another question that says, do you have any advice for presenting your inclusivity in this space for organizations whose funding may be at risk if they do so? I know that is a bit of a tough question uh,
Mhm.
that we are all contending with in today's climate.
This is Brody speaking. The first two things that come up for me is like not necessarily stopping a service, but renaming it. Um, so instead of saying gender affirming care or trans inclusivity or disability inclusive, like framing things in terms of like wellness and improving quality of life, right? All of those things are true. It's just a different name that isn't currently being targeted by the administration. Um, this is a question that goes for the question about DHHS, and having trainings either mandatory or strongly recommended or provided, as well as this question. Especially for providers, we are bound by codes of ethics. And those codes of ethics emphasize things like client care and client empowerment, client safety, respect, cultural competency, um, collaborating with colleagues for things like consultation or supervision, recommending additional trainings to expand our scope of practice, or not even our scope of practice, but our competency to provide care. All of us have codes of ethics that we are bound to. And those codes of ethics support continuing to do this work. So I think grounding in codes of ethics can be just as powerful when the laws aren't necessarily on our side at the time being, and even when they are.
This is Tiara speaking. Thank you so much. The last thing that we have in the Q&A is a comment, and it is a great point to close on. It says, this is not a question, but more of an acknowledgement of all the work and information you guys are providing. It's super helpful, and I hope This helps people disentangle stigmas from trans people. So, on that note, that is our time for today. As we close, on behalf of the Michigan Department of Civil Rights, I would like to thank all our presenters for spending this time with us today. It is our hope that those listening walk away with understanding the need to create more equitable healthcare system for all. For those interested in learning more about the work of the Disability Rights and Compliance Division, please visit the Michigan Department of Civil Rights website at www.michigan.gov/MDCR. Also, we would like to invite you to our virtual ADA commemoration scheduled for Thursday, July 10th from 9 a.m. until 12 p.m. This commemoration is being held in honor of the 35th anniversary of the ADA. We have a dynamic list of speakers lined up for the event, including Sarah Hendren, who is a renowned speaker, writer, design researcher, and artist known for her significant contributions to accessibility and contemporary art and design. Registration information will be sent out at the close of this program, and you can also find it on the MDCR webpage. We hope to see you all on July 10th, and we thank you again for joining us today. Bye for now. Thank you so much to all of our presenters.